Thanks, Maya. Okay, let me share my screen. Okay, can you guys see my PowerPoint?
Yeah.
Okay, great. All right, so like Maya said, I am an OBGYN. I'm actually subspecializing in OBGYN, which I'll talk about shortly, but I'm going to kind of go over OBGYN, which stands for obstetrics and gynecology, and sort of my path to get there and what being an OBGYN doctor looks like. So similar layout to, I think, some of the other presentations you guys have had. I'll talk a little bit about myself first and then let you guys ask some questions. And then a little bit about OBGYN as a specialty and what that sort of looks like practically. So this is a picture of me in Mexico City. I love to travel. So this was, I did a rotation in Mexico City in residency during Day of the Dead. So this is the festival they were having in the main square. I was born and raised in Orange County, so down here in Southern California. I went to Rosary for high school, which is an all-girls Catholic high school in Fullerton. And then I went to UC San Diego for undergrad, and then UC San Francisco for medical school and residency, actually. And now I'm down here at UCLA doing a fellowship, which I'll explain shortly, which I'm in the middle of now. So I have my MD, which is my medical degree, and my MPH, which is a master's in public health. If you've seen, a lot of the news coverage going on with coronavirus, the people they interview on TV, where it says, epidemiologist or someone who does health policy, most of those people have a degree in public health. Often not just a master's, like a doctorate, so like a PhD. But that's the kind of specialty looking at how to study illness in a community. So in a county or a state or the country or the world, and then how to deliver it. So health systems, hospitals, clinics, that kind of stuff, and health policy. So all the laws that govern how we deliver healthcare. This is my educational timeline. I graduated from Rosary in 2007, and then I graduated from college, undergrad in 2010. I took 1 year off, so I actually graduated college in 3 years, which I was able to do because I had so many AP credits from high school, which I know you guys have a lot of experience with and also heard about in other presentations, the benefit behind doing AP classes. But it allowed me to graduate a year early and sort of save some of that money. So I spent what would have been my 4th year of college working and getting some experience in a lab. Then I went to medical school at UCSF, which was 4 years, graduated in 2015. Did my residency in general OB-GYN at UCSF also, which is 4 years. And now I'm at UCLA. So residency, I know you guys have had a bunch of these. So residency in medical school, you pick your specialty. Residency is sort of you training as a doctor in whatever specialty that is. So it can be anywhere between 3 and 9 years. So OB-GYN residency is 4 years all across the country, and you learn how to be a general OBGYN, which I'll talk about again a little bit later. Once you finish with residency, so once I graduated in 2019, I could have decided to just be an attending doctor, working, making money, and practicing as an OBGYN at a hospital, in a clinic, in kind of whatever setting I wanted. But I decided I wanted to subspecialize. So I am in my fellowship right now, which is additional training past residency. So that's what I'm at UCLA for. So this fellowship is another 3 years. So I'll graduate next June. One of the years of my fellowship was I did no work in the hospital. So I was only doing research. And I decided to get my master's in public health during that year also, since that's one of my interests. And the second 2 years of my fellowship, I'm full-time in the hospital. So that's what I'm doing now. And my fellowship is in GYN cancer, so GYN oncology. So I operate on patients with GYN cancers. I see them in the clinics. I do a lot of surgery, chemotherapy, end of life sort of care. So I don't deliver babies anymore at all. So I know everyone here is OBGYN and they think about babies, which is not wrong, but there's a lot more to it. And I don't do any babies anymore. Briefly to go through my educational timeline. So again, I went to high school at Rosary, took some AP classes. So my GPA, I don't actually remember what it was, but it was 4 point something with the weights from the AP classes. And then in terms of extracurriculars, I know you guys, there's, the other presentations I saw kind of talked about what people did during high school. I played sports. So I was on the varsity softball team. And then I did tennis for the first couple years of high school as well. And then I was on ASB, so Associated Student Body, Student Council. I don't know what they're calling it these days. And then I did kind of various volunteering and service projects. So I think I was part of the science club, and we put on some blood drives at my high school. Got out into the community and we did a lot of blood drive work, but did some blood drives in the community and kind of volunteered in sort of various other aspects that were related to sort of science or medicine. I actually never shadowed a doctor in high school, but that would have been a good opportunity. There's a lot of programs that allow high school students in or to volunteer in hospitals. So that would have been a good opportunity, but I didn't know about that when I was in high school. So I kind of funneled my interests into other things. Again, went to UC San Diego for undergrad. I majored in human biology and I had a lot of fun. So I did sort of non-healthcare related extracurriculars. I actually danced competitively. So folclórico is a type of Mexican folk dancing. So I did that all 3 years of college. And then I also did salsa dancing, another kind of Latin dance. And then my kind of other extracurriculars. So I was part of this group called Alternative Breaks, which is this AB at UCSD, which I think there's versions of it at various college campuses, and it's called different things, but it's basically like an alternative spring break. So the idea is, instead of going to, Cancun to party, to Mexico to party, you spend your, week or two of spring break going to another community, or even actually staying in your own community, and providing some service. So volunteering, doing a service project, engaging with the community in some kind of meaningful way. So I went to Brazil, I went to Ghana, and then I went to Mexico a couple of times. We did kind of various little things, in a week, 2 weeks. The projects are fairly basic. So I think we helped do some construction. I did some basic English teaching, kind of projects like that. And honestly, I feel like I gained more from the experience than probably the communities I was in, but I spent a lot of my time as a part of this group because we met throughout the year, and it was really great. I did also, towards the end of college, start working in a cancer lab. So at that point, I knew I was interested in going to medical school. So I actually started as a lab assistant, which means I took out the trash and I did basic organizing and stocking of the shelves. And then I gradually moved up over the 2 years that I was in the lab to be a research associate. So this is the lab. This is their little logo in the bottom left. They worked on tapeworms mostly, and they focused on the molecular biology of cell division and how that contributes and relates to cancer biology. So very, very basic, what we call basic science. So there's a lot of, pipetting and lots of, plates, the Petri dishes that you probably have used in biology class. None of which I do anymore, but which was a great experience at the time. And then, like I said, ended up being able to graduate in 3 years because of the AP credits that transferred over from high school. And then I took my MCAT my junior year, my third year. I came up to San Francisco for medical school, which was 4 years. And then again, spent my OBGYN residency in San Francisco, which was also 4 years. I know you guys have had a couple of talks from medical doctors. So, I didn't want to be too repetitive in the slides, but medical school, the curriculum's changing a lot, but generally a year and a half at this point of lecture-based school. And then, 2.5 to 3 years of being in the hospital. So in the hospital doing clinical work, learning how to be a doctor, learning how to do research, since that's an increasingly important part of being in medicine, and learning how healthcare is delivered. So what are the issues that come up with running a clinic, with running, a hospital, et cetera. And then my OB-GYN residency, like I mentioned before, you learn how to be a general OBGYN. So in the next part, I'll kind of go into what OBGYN is. But before I do that, any questions about the educational part?
So sorry, one of the questions I had for you was, I heard that for residency, it's like different compared to others, since like it's like, say you went to residency, you like did multiple different like careers, I guess, like you worked in the emergency department, like ICU, stuff like that. But then is OBGYN the same for residency, or is it like a different department in general?
It's a totally different department. So actually, that's a good segue into what OBGYN is. So OBGYN, the OB stands for obstetrics and the GYN stands for gynecology. And I just kind of pulled these definitions out from the internet, but basically the obstetrics part has to do with pregnant people. So pregnant women and childbirth, essentially. So taking care of women throughout their pregnancy and then during their labor and their delivery, whether that's a C-section, a vaginal birth, whatever it is, and then kind of immediately postpartum. Which means right after they deliver. And then GYN, the gynecology part, is basically taking care of the variety of other things that come up with people who have a uterus and ovaries. So, abnormal bleeding, sexually transmitted infections, pelvic pain, contraception. Actually, sometimes like bladder issues also kind of overlap into our field as well. So OBGYN is actually completely different. There's some overlap between, some women come into the emergency department, for example, with abdominal pain. And there's a lot of things that could be going on, some of which are related to their reproductive anatomy, right? So they could have an ovarian cyst, for an example, or they could have appendicitis. And so we do have some overlap with the emergency department, and we do, many programs will have a rotation in residency where you're in the emergency department just to learn what that's like. But OB-GYN is its own totally separate bubble. So I like to just put down here, like think of us as reproductive specialists. I think that's kind of the easiest way to think about it. So here, these are kind of like career options, which I think the left side is pretty much what our residency looks like. So where it says generalist, so a person that graduates from an OBGYN residency and decides to not do an OB-GYN subspecialty would do all of these things on the left. So they would be considered what's called a generalist, and they would do, prenatal care. So women that are pregnant, they take care of them in the clinic. They do ultrasounds. They, make sure the pregnancy is going well and everything's healthy. They do office-based kind of gynecology. So that's being in the clinic and seeing patients that have, like I said, pain, or they have, they want to be tested for STDs, or they have abnormal bleeding. What does fall into OB-GYN also is sometimes gender affirming care, so trans men or women. So there actually are some OB-GYNs that specialize in like hormone administration, so giving testosterone or estrogen, or doing hysterectomies for trans men, for example, and then taking care of these patients through menopause. So OB-GYN is really appealing to a lot of people because you really get to take care of your patients from kind of like birth all the way to death, really along the spectrum of life. And then hospital gynecology can be a variety of things, but basically some of the most common reasons people are admitted to the hospital are pelvic infections. If someone has an ectopic pregnancy, sometimes those have to be managed with surgery. And then other sort of planned surgeries for fibroids or bleeding, or a variety of other things that can come up with the reproductive tract. So someone that, if I had graduated from residency and just wanted to go straight into working and being a doctor, I would have been a generalist that could do all of those things on the left. Okay. And then on the right side are some of our subspecialties. So if you decide, okay, I finished my residency and I really specifically like this one area of OB-GYN and I want to become a specialist in it and only practice this, you can do a fellowship. So that's what I'm doing now. And mine is highlighted at the bottom in red. But these are some of the other specialties in OB/GYN. So MFM, or what's called maternal fetal medicine, those are doctors that take care of high risk pregnancies. So women that have had that have preeclampsia, which is high blood pressure in pregnancy, that have diabetes, that have had a kidney transplant, that have, heart conditions, or pregnancies where the baby has some abnormality, like a heart condition or a condition in the brain that needs specialty care. These are the doctors that do it. REI is called Reproductive Endocrinology and Infertility. So those doctors deal primarily with patients who are having issues with infertility, and the endocrinology piece is more rare, but also on the table. So I don't know if you guys have ever heard of PCOS, polycystic ovarian syndrome. It's in a lot of the social media nowadays. There's a lot of like advocacy around PCOS, but there's some sort of hormonal imbalances related to the reproductive tract that these doctors specialize in taking care of. And for the infertility piece, they do like IVF. So they do a lot of that stuff themselves. Family planning, so birth control or contraception and abortions, and then UroGYN, which has to do with pelvic organ prolapse and some bladder issues, and then gynecologic oncology, which is my fellowship. So I strictly deal with patients that have GYN cancers. So cervical cancer, uterine cancer, ovarian cancer, vaginal vulvar cancer. And we do their surgery, we do their chemotherapy, and then, I'm with them all the way, and their families all the way often till the end of their life. So you can see how your life could look very different depending on what you choose in OBGYN, which I actually think is part of its appeal for some people because there's so many different options. Let's see. Okay. So just for some context, this is the female reproductive system. So this is kind of what we specialize in. So I know you guys probably recognize this from biology, but vagina, cervix, uterus, the fallopian tubes, and the ovaries. This is what we specialize in. And then I just have a graphic photo. So it's just this picture of a specimen from surgery. So this is what a normal uterus, cervix, fallopian tubes, and ovaries looks like. So we took this patient's uterus out. I think she had, I don't actually remember, she had a polyp and bleeding or something, but this is what it looks like normally from the outside. So there could still be something abnormal on the inside when the pathologist, cut it open to look inside, but from the outside, this is a normal appearing female reproductive tract. So like I said, things can look very different depending on what you choose, but just because people most commonly think of labor and delivery and pregnant women when they think about OB, I just put some photos of like a day on labor and delivery, generally pretty fast paced. There's a lot happening. Labor and deliveries are often very busy, although it depends on what hospital you're at, but you are admitting women in labor. So like the woman in the top left, she's laboring. Some women need to come into the hospital to be induced. So they need to have medicines given to them to make their labor come on because they're either past their due date or they have some, condition that warrants them being delivered before they go into their own sort of natural spontaneous labor. The woman in the middle is just got a C-section for twins. So, we do C-sections also on labor and delivery, both planned and not planned. And then the woman in the top right is just getting an ultrasound, but labor and delivery also functions as kind of like an emergency department for pregnant women. So if a pregnant woman gets in, falls, or she has abdominal pain or a headache or bleeding, vaginal bleeding, they come to labor and delivery to be assessed. So you do that all day also. So labor and delivery, like I said, is very fast paced. Things can change at any moment, even if it's slow, anything can happen at any time. So for people that like to be quick on their feet and like to have some unpredictability about their day. Okay, again, there's going to be some surgical specimen photos on the next slide. So my day looks very different than that. I'd say most of the time I'm in the operating room. So 3 to 4 days out of the week, I have scheduled surgeries. So, anywhere between 1 and 3 or 4, depending how long the surgeries are. And all of them are really to take out cancer. So you saw the normal uterus a couple slides ago. So now you see this uterus on the right that looks super abnormal, right? It has this huge growth coming out of the side of it that was causing that woman a lot of pain. Obviously, she came in and we did her imaging, her CT scan and her ultrasound, and saw this big thing. And the only way that you can know it's cancer is to take it out. We don't typically biopsy these masses just because you can spread cells all in the abdomen and the pelvis. And so she went to surgery and we took it out. Luckily, it was not cancer for her, but it was very abnormal. The middle slide is me holding a spleen. So this was the first spleen I took out. It had some ovarian cancer that actually implanted on the spleen. So in my specialty, we learn how to do surgery, not just in the pelvis. So we operate on the bowel and in the upper abdomen as well, depending on where the cancer has gone. And then on the left is actually a uterus, an immediately postpartum uterus. So this woman had a C-section. So you see that incision at the very top of the uterus that's kind of sewed up. That's where they took the baby out. And then they sewed it back up just quickly. And then the labor and delivery team handed the surgery over to us because this woman's placenta, which you can see bulging out in the bottom, it's not supposed to look like that. So that was bulging out through her uterus and almost to her bladder. So we had to do kind of special surgery to make sure, we could get her uterus out and keep the bladder safe because that placenta was not going to come out on its own. So she had to actually have a hysterectomy, which means taking out your uterus after her C-section. So this is most of my days. I spend about a day to a day and a half a week in clinic. So, managing chemotherapy, talking to families and patients who are at the end of their life and deciding what that's going to look like, and seeing some, my post-op patients or patients that are about to go in for surgery. But most of the day I'm in the operating room. So this is where I operate. So as opposed to just the picture from before in the pelvis, we operate in the whole abdomen. So most of our incisions are up and down the whole belly. So that's kind of what I do. I think I repeat a lot of the advice that a lot of other presenters have given, but a couple of the things additionally that I thought about is to not stress about your pedigree. So the name of the college that you go to. I think people get excellent educations. I went to a UC school, which is a public school, but is reasonably high on the rankings, whatever rankings are out at the time. But people get excellent educations at state schools, at private schools, at Ivy League and non-Ivy League schools. So don't stress too much about the name of the school that you're going to, especially for undergrad. Also to do the extracurriculars that you actually enjoy, not what you think is going to look good on a resume. So I had plenty of classmates in medical school that had majored in college in music or English or history or something else. And while everyone has to do certain, requirements to apply to medical school, they had really interesting stories and they had chosen those majors for a reason. And, you want to stay true to yourself, or else you'll just sort of come across as someone who is, just done things to check the boxes, and your sort of passion behind what you're doing will be harder to translate if you don't choose something that you actually enjoy. Be prepared and organized. So whether you have, a test, whether it's a, test in high school, the SAT, the MCAT, an interview, whatever it is, be prepared, be organized, do your homework, both literally and figuratively. You should prepare yourself and have a sense of what timelines and deadlines are coming. And then don't compare yourself to other people. I saw this on someone else's slide and I thought it was really important. This is not a race. So again, I had med school classmates that started when they were in their 30s. People try things and they're not a good fit. So you try something else and everyone's path is going to look different. So don't compare yourself to other people as much as possible. And then enjoy as much as you can the process. I had a lot of fun. I mean, I'm glad I enjoyed myself in college and medical school, and didn't just, do the things that I thought were checking the boxes. And it's really important to, live your life, and have fun. And with that, any questions?
Yeah, I have two questions.
Sure.
So my first question is, how many APs did you approximately take in high school? And my second question is L&D a subspecialty? Like, can you do a fellowship in labor and delivery?
That's a great question. So the first question, how many APs? I don't know that I remember off the top of my head, but I took, I'd say, most of what was offered at my school. So I took, um, I'm trying to think, I took AP history, English, Spanish, calculus, AP bio. I did not take AP chem because I don't know, I just didn't. It was offered at my high school, but I just didn't. And then I actually, one thing to just mention is I didn't qualify for AP history based on my grades. I think we took it junior year, and I didn't qualify for it based on my grades as a sophomore, but I felt like I could do the work. So I basically petitioned myself to be in it. And so I went to my counselor and said, I think I can do this work. Can you please consider letting me in? And they did, and I did fine. I don't know how things work at your high school, but I took probably 4 or 5 at least AP classes. And then labor and delivery, no, is not a subspecialty. So labor and delivery would be something that you graduate from a 4-year regular OB/GYN residency already knowing how to do it, and you could go straight into working and doing and working on labor and delivery. You don't need to do additional training. Some people opt to do, there's these sort of unofficial fellowships that people opt to do just to get more experience. So there's some people that decide to become what's called a laborist. So they graduate from residency and they don't want to do anything else but labor and delivery. They don't want to be in clinic. They don't want to do any gynecology. They just want to be on labor and delivery. And so there's some people carving out, this very niche generalist sort of, career, but you don't need to do any extra training.
All right, so we have some couple of questions in the chat. Would you like me to read them out to you?
Sure, that'd be great.
Okay, so one question is, what type of volunteer work did you do? I think this is for high school or college.
In high school. Yeah, so most of the volunteering I did was through the science club. So I think honestly, I spent a lot of my time with we had a partnership with the Red Cross. And so, calling people to donate blood, helping put on blood drives. I think I did a couple outreach to junior highs, science outreach to junior highs, science fairs, that kind of stuff. So that was most of my volunteering. There's a lot of people that I went to medical school with that actually volunteered in hospitals, like I said, which I didn't do. I didn't know that existed, but you could volunteer to be, I think, a patient navigator or patient, you accompany patients, take them up, if they come into the lobby, you take them up to the right clinic, or you take them to radiology to get their x-ray, or you greet people. So there's lots of opportunities for volunteering specifically in hospitals. But it could be anything. You could do any kind of service, is, life experience that's contributing to kind of your path and what you could talk about to someone that's asking you about your path.
All right, so the next question, sorry. Okay, we have more questions about being an OBGYN. So after becoming a generalist OBGYN or attending after residency, what does your schedule look like? Do you have to go on call for every delivery, or how does that work?
Great question. So basically the answer is you get to choose. So if you graduate from residency and you want to go into, let's say, private practice, I think a lot of people will go into a group practice. So it's you and you join a practice of 5 or, let's say 6 other OBGYNs. You could potentially do, let's say, Monday, Wednesday, Friday, you're in clinic doing prenatal care, doing, regular gynecology. And then Tuesday, Thursday, you're on labor delivery. And then, once every 7 weeks, you're on for the weekend, or once every 3 weeks, you're on Saturday, or overnight Saturday or something like that. So you'd switch off with your partners. Alternatively, some people have the kind of model where, you are in clinic Monday, Wednesday, Friday, you're in labor and delivery Tuesday, Thursday, but you have your prenatal patients. So you have your pregnant patients that you've been taking care of, and you're on call, and you can get called into the hospital whenever they deliver. So if they are getting delivered, if they come into the hospital in labor Wednesday night and you've just been in clinic all day, you still come into the hospital and you do their delivery. That's kind of phasing out, because as you might kind of guess, like, that's really exhausting, because you could be, in the hospital all day and then have to come back in the middle of the night and then go to the hospital the next day. And people are more and more, wanting to create this sort of work-life balance that makes sense for them. So I'd say more and more it's moving towards a call schedule. So you just split, you're on labor and delivery certain days, and you take care of whatever patients come in labor to deliver them. And then you go home. And what that means is it's better for your sort of like predictability of your schedule, but you won't necessarily deliver the patients that you take care of in clinic. Yeah, so there's some variability there, but I'd say that tends to be the more common model that I see that it's moving towards.
Okay, we had a person raise their hand, but I think they just put it down. So I'll just read off the chat. So is OBGYN separate from something like neonatal surgery, or would that be totally different specialty or subspecialty?
Yeah, good question. So neonatal surgery, there are sort of two pieces to that. So fetal surgery, so when the fetus or the baby is still in the mom's uterus, is still inside. There actually are some procedures and surgeries that are done on those babies, those fetuses. And that often is, depending on what the procedure is, some combination of an MFM, so an OBGYN, high-risk OB doctor, and a pediatric surgeon, who is someone who trained through general surgery. So I think you guys met Dr. Moyer probably a couple weeks ago, or sometime within the last couple of months. So someone who trained in his specialty and did a general surgery residency and then a pediatric surgery fellowship. Them and an MFM, so a high-risk OB doctor, are often do those procedures together. Strictly neonatal surgery, so after the baby's born and has to have a heart procedure or an abdominal procedure, those are all done by the general sort of pediatric surgeons. So when the baby's still inside, they're usually joint procedures.
Okay, that's really cool. I didn't know general surgeons would collaborate. So we have another question asking, can you just be an sorry, I'm butchering this, obstetrician?
Yeah, that's right. Yeah, you can just be an obstetrician. So you have to train in obstetrician and gynecology. So you have to do a full residency to learn all the things. But if you graduated from residency and just wanted to do the obstetrics part, so you only want to take care of pregnant women and you only want to do labor and delivery, so C-sections, vaginal births, you could just do that. So there's a lot of people actually that just choose to do that, but you have to do a full 4-year OBGYN residency first.
All right, so I think that's like it for all the questions in the chat. I'll ask you one more question.
Sure. Yeah.
So like from all the surgeries and the fast-paced and unpredictable labor and deliveries, like what is your favorite part about your job?
Good question. Well, part of the reason I chose oncology, so the kind of cancer piece of OBGYN, is, and actually this is true for other parts of OBGYN, but especially true in cancer, getting to know patients kind of on a deeper level than just kind of one encounter or a couple encounters. I really get to know their families really well, their kids. I sometimes take care of, unfortunately, young patients with cancer. So sometimes their parents, their siblings, and we really all make decisions about, the patient's life, dictated by them primarily, but taking into consideration the whole family. So I really love getting to know patients more on a personal level and getting to meet their families and kind of build a relationship over time, which is part of why I chose, like I said, oncology, because you get more of that continuity than, for example, if you just decided to work, let's say there's some people that do just labor and delivery shifts, they do like 8 to 12 labor and delivery shifts a month, and that's their full-time work, which is awesome and has a lot of pros. But the one con is that you don't get continuity with your patients. So for me, I really love the kind of deeper relationships that I build with my patients.
Okay. Is it okay? We have one more question.
Of course, yeah.
So they asked, like, are there options for doctors to work abroad for shorter periods of time without necessarily completing exams like the USMLE? I don't know.
So, yeah, so the USMLE, there's a step 1, 2, and 3. Some of those you do as a medical student, and then step 3 you do as an intern or a first-year resident. There are the sort of like broad answers that there are plenty of opportunities to volunteer and work abroad for short periods of time. In generally speaking, to deliver medical care, you should have some level of medical training. So, I mean, I do know I have plenty of friends in medical school who, they were, second, third year, first, second, third year medical students, and they did rotations or did electives abroad. But they had but they weren't, necessarily operating, but they were doing some level of, taking blood pressures and taking histories. So, understanding from people what's going on and what their family history is, or how long their symptoms have been going on. And so we're helping in that capacity, which they were sort of like appropriately trained and ready for. But, I wouldn't expect to go, as a first year medical student and go abroad and be able to, operate or provide some other kind of, more specialty medical care without training. But that being said, if you finish medical school and you enroll in a residency, you will by default have, done 2 of the 3 USMLEs already in medical school, and you would do the third one the first year of residency. And there are a lot of people that do, electives and rotations abroad. So I actually went to Mexico for a month in residency. I had many co-residents that we have a partnership with a hospital in Uganda. So they went and did surgery at that hospital in Uganda. So they weren't yet board certified, doctors, but they sort of were at the appropriate level of training to be able to deliver some of that care in other countries.
Okay. Well, do we have any other questions? I'll just give it another 30 seconds.
Sure.
Okay, well, I think that should be it of all the questions. Thank you everyone for joining us today. And thank you, Dr. Erica Manrriquez. All of us really loved, I mean, I at least, even though the pictures were really gory, I think they were really cool. So thank you for showing that. And yeah, thank you again, everyone, for showing up today.
Bye, guys. Take care.
Bye, everyone.